Hi everyone, this is Immunology Unit 4, Lecture 3. We'll be going over rubella and torch. So here are your objectives. So these are going to be more of the summarizing type notes. So just follow along and summarize as you feel is necessary. So, rubella. The rubella virus is composed of single-stranded RNA and is a member of the Togaviridae family. The area of entry into the human body is the upper respiratory tract and possibly the lymphoid tissue, where it establishes intracellular reproduction in a susceptible host. The virus can be propagated in a variety of cell lines, but most rubella infections are diagnosed serologically, which is quicker and easier. German measles, or rubella, is a mild contagious illness characterized by an erythematous maculopapular rash that is observed primarily in children 5 to 14 years old and in young adults. In children, the first sign of illness is the development of the rash. In adolescents and adults, the rash is preceded by a 14 to 21 day period of headache, malaise, low-grade fevers, and cold symptoms. The disease is commonly called the German or 3-day measles, and the prognosis of rubella without complications is very good because it's usually benign and self-limiting. A possible complication that can develop is a transient arthritis involving the knees, knuckles, ankles, and elbows. So congenital rubella is the contraction of rubella during pregnancy, and this can pose a serious health risk. Maternal infection can result in spontaneous abortion, stillbirth, or infection of the fetus. And as many as 85% of infants infected during the first 8 weeks of gestation have detectable defects by age 4. The classic abnormalities associated with rubella syndrome include congenital heart disease, cataracts, and neurosensory deafness. So the immunologic response, antibodies to rubella appear as the rash fades, and those are going to be both IgG and IgM. Rubella IgG antibodies persist through life, and IgM antibodies decline after 4 or 5 weeks. Fetal infection is usually accompanied by early placental transfer of maternal IgG. Substantial levels of fetal IgM are produced by mid-gestation. Therefore, most screening for congenital infection is accomplished by quantitating IgM. So your clinical indications, we're going to go over 2 infection scenarios. So if you have sera available at the onset of symptoms, you need to collect 2 serum samples, one at the onset of symptoms and a convalescent serum obtained 5 to 7 days later. Both specimens should be tested in parallel on the same day using the same test and appropriate controls. A 4-fold or greater rise in antibody titer, together with clinical symptoms, is diagnostic for this infection. Next is if you do not have sera available at the onset of symptoms. In this case, then testing for specific IgM antibody in serum collected several days after the onset of symptoms can help in diagnosis. IgM antibodies drop quickly and they can disappear within 4 weeks. But obviously, with it disappearing so quickly, a negative result does not exclude the possibility of a recent rubella infection. A congenital infection can be confirmed by isolating the virus from throat washings, urine, and other body fluids. However, the preferred methodology is serologic testing. Testing for the presence of specific IgM antibody is diagnostic in a neonate, and this is because IgM does not cross the placenta. So if a baby has IgM antibodies, then they've definitely had rubella. Determining the immune status. Detectable levels of antibody are indicative of past infection with rubella virus, and these individuals are considered immune. So we have the hemagglutination inhibition test. Both IgG and IgM antibodies can be detected. Rubella virus has the ability to agglutinate chick erythrocytes. When patient sera containing the antibody is incubated with rubella antigen, binding is going to occur. To determine whether the binding has occurred, the chick erythrocytes are added. Any unbound rubella antigen present is free to agglutinate those erythrocytes. The test is valid providing the antigen back titration confirms that the correct antigen dilution was used and controls show that nonspecific inhibitors and agglutinins were removed. The endpoint is read as the highest dilution of serum that completely inhibits agglutination. Recent rubella infections are demonstrated by a fourfold or greater rise in titer between acute and convalescent sera. So a high titer is considered greater than 8, 1 to 8, and this indicates immunity to rubella disease. Next, we have the passive hemagglutination. So stabilized human red blood cells are coated with soluble rubella virus antigen, and these sensitized red cells will agglutinate in the presence of rubella antibody. The passive hemagglutination test is most useful in detecting immunity because it is very sensitive to IgG. We also have some solid phase immunoassays. So the antigen capture assays, these assays use rubella virus antigen absorbed to solid phase, and after incubation, the rubella antibody binds to the antigen. This assay is very specific for IgG, but you can get false negatives for IgM. False positive results may be encountered in patients with IgM rheumatoid factor as well. And then we have the antibody capture assays. These assays use a solid phase coated with anti-human IgM globulin. After incubation and washing, reagent containing rubella antigen is added. We also have sucrose density gradient ultracentrifugation. Specific IgM antibodies to rubella can be detected by physical separation using this method. In this methodology, it is possible to separate IgG and IgM antibodies to test the pure antibody using hemagglutination inhibition or solid phase immunoassays. So we do have vaccines. There are 3 strains of live attenuated rubella vaccine that were developed and licensed in 1969. These vaccines have proved safe and effective with minimal side effects of rash, fever, arthritis, and lymphadenopathy. Federal support was given to the immunization program following a worldwide epidemic from 1962 to 1965, and in 1969 more than 45 million doses were administered to children, resulting in a marked decrease in the occurrence of the disease. However, 10 to 15% of the adult population in the US has no detectable levels of antibody, so the potential for another outbreak does exist. Reinfection is possible but not likely. It all depends on how successful your body was at producing antibodies to the rubella virus. Reinfection is demonstrated by a fourfold rise in pre-existing antibody titer and is more likely to occur in immunized persons with a low antibody level. Immunization should be given after 12 months of age. If given as part of the MMR regimen, which is measles, mumps, and rubella, we don't do it until 15 months of age. If given prior to 12 months of age, maternal antibodies that are present can interfere with the immunization. Contraindications, there is a potential risk to the fetus if the mother is immunized during pregnancy. and this may cause development and congenital rubella syndrome. Therefore, pregnancy is a contraindication for vaccination. In addition, women of childbearing age should avoid becoming pregnant for at least 3 months following the vaccination. Also, persons with an impaired immune system, people receiving radiation treatments, or persons being treated with corticosteroids to suppress the immune system should not receive this vaccination. All right, so let's get back to the basic premises. If I vaccinate or immunize an individual for rubella, what type of immunity does this patient have? Would it be active, passive, adaptive, or natural? You should know that. Natural would be non-specific mechanisms involved in fighting infection, and this would be like your skin, the pH in your stomach, so it's not that. Adaptive occurs when immunocompetent cells are transferred to a non-immunocompetent host. Passive occurs when antibodies are produced by another person or animal, and those antibodies are transferred to the patient, giving temporary immunity. This occurs through breast milk from the mother. And active immunity is your correct response. The patient is presented with an antigen, whether it be by infection or immunization, and this forms antibodies. So our torch panel, TO, stands for Toxoplasma gondii, R stands for rubella, C stands for cytomegalovirus, and H is for herpes virus. Procedures that specifically evaluate IgM are frequently used to detect cytomegalovirus, herpes virus, toxoplasma, rubella, and treponema. The names of some of the tests for some of these agents have been grouped under the acronym TORCH. So this is a common panel that is run to determine if a patient has any of these antibodies. And that is it for this lecture, and I'll see you guys in the next one. Don't forget to go take the quiz on Canvas.